Hi friends, in this video we're going to talk about chronic renal failure, and if you like this video make sure to give it a thumbs up and subscribe below to my channel. I create new nursing content for pre-nursing students, nursing students, and nurses, and we have new videos every week, but let's get into it. So chronic renal failure. It's the end result of a gradual progressive loss of kidney function. Causes include chronic infections, vascular disease such as hypertension, obstructive processes such as renal calculi, collagen diseases such as systemic lupus, nephrotoxic agents like different drugs, and endocrine diseases such as diabetes or hyperparathyroidism. It's generally progressive and produces major changes in all of the body systems. And the final stage of renal dysfunction, end-stage renal disease, is demonstrated by a glomerular filtration rate of 15% to 20% of normal or less. And renal failure results when the kidneys cannot remove the body's metabolic waste or perform regulatory functions. So, substances that are normally eliminated in the urine accumulate in the body as a result of impaired renal excretion, affecting endocrine and metabolic functions, as well as fluid, electrolyte, and acid-base balance. So, accumulation as renal function declines, the end products of protein metabolism, which are normally excreted in the urine, accumulate in the blood. Adverse effects we'll see are uremia, which develops and adversely affects every system of the body, and the disease tends to progress more rapidly in patients with significant amounts of protein or have elevated blood pressure than those who do not. So the pathophysiology of chronic renal failure includes pathologic features such as fibrosis, loss of renal cells, infiltration of renal tissues by monocytes or macrophages. We can see proteinuria, hypoxia, extensive angiotensin II production all contribute to the pathophysiology. In an attempt to maintain the glomerular filtration rate, the glomerular hyperfiltration, which results in endothelial injury. You'll see proteinuria results from increased glomerular permeability and increased capillary pressure. And hypoxia also contributes to disease progression. Angiotensin II increases glomerular hypertension, which further damages the kidneys. So this is a nice chart overview of that pathophysiology. You can see the hyperfiltration of the glomerulus. It's going to increase the glomerular permeability, which increases the filtration of proteins and macromolecules, which leads to nephrotoxic inflammation or remodeling, or proteinuria and dyslipidemia, or we'll see an increase in RAS, which will lead to nephrotoxic inflammation and remodeling. So both of them lead to that. And once this happens, you'll see that tubular interstitial fibrosis, and you'll see the decreased glomerular filtration rate, decreased urine output, and systemic complications. So predisposing factors for chronic renal failure include diabetes, being age 60 or older, kidney disease present at birth, a family history of kidney disease, an autoimmune disorder, a bladder outlet obstruction, and there are differences when it comes to race as well. Precipitating factors, so occupational hazards such as overexposure to toxins and some medications, a sedentary lifestyle which increases hypertension and atherosclerosis, and a diet. So clinical manifestations. We may see peripheral neuropathy. This is a disorder of the peripheral nervous system that is present in some patients. They'll have like pins and needles in their fingers or their feet, severe pain and discomfort. They may have restless leg syndrome and burning. They may report burning feet can occur in the early stages, and that's due to the peripheral neuropathy. So different complications of chronic renal failure include hyperkalemia due to decreased excretion, metabolic acidosis, and excessive intake such as diet, medications, or different fluids. Pericarditis due to retention of uremic waste products and inadequate dialysis. Hypertension due to sodium and water retention and the malfunction of the renin-angiotensin-aldosterone system. Anemia due to decreased erythropoietin production, decreased red blood cell lifespan, bleeding in the gastrointestinal tract from irritating toxins and ulcer formation, and blood loss during hemodialysis. And also bone disease and metastatic and vascular calcifications due to retention of phosphorus, low sodium calcium levels, abnormal vitamin D metabolism, and elevated aluminum levels. So assessment and diagnostic findings. So the glomerular filtration rate and creatinine clearance decreases while serum creatinine, which is a more sensitive indicator of renal function, and BUN levels increase. Sodium and water retention. Some patients retain sodium in water, increasing the risk of edema, heart failure, and hypertension. Acidosis, metabolic acidosis occurs in end-stage renal disease because the kidneys are unable to excrete increased loads of acid. And anemia in end-stage renal disease because erythropoietin production decreases and profound anemia results, producing fatigue, angina, and shortness of breath. So we can also look at the urine. So usually in the stage of algeria, we'll see 400 milliliters in 24 hours, or urine may be absent, which is anuria. The color may be abnormally cloudy and may be caused by pus, bacteria, fat, different particles, phosphates, or urates. It could be dirty and brown and have sediment such as red blood cells, hemoglobin, myoglobin. Specific gravity is usually less than 1.015, and if it's less than 1.010, it reflects severe renal damage. And osmolality less than 350 is indicative of tubular damage, and urine-serum ratio is usually 1:1. Creatinine clearance may be significantly decreased, less than 80 milliliters per minute in early failure, but less than 10 milliliters per minute in end-stage renal disease. Sodium, more than 40, because kidney is not able to reabsorb the sodium. And protein, high-grade proteinuria strongly indicates glomerular damage when red blood cells and casts are also present. So we can also look at the blood. We will usually see a BUN or creatinine elevated, usually in proportion. Creatinine level of 12 suggests end-stage renal disease. A BUN of less than 25 is indicative of renal damage. If we look at a CBC, the hemoglobin decreases because of anemia, usually less than 7 or 8. Red blood cells lifespan decreases because of erythropoietin deficiency. We can look at ABGs. The pH will be decreased. Metabolic acidosis if less than 7.2. This occurs because of the loss of the renal ability to excrete hydrogen and ammonia, or end products of protein catabolism. Bicarbonate and PCO2 is decreased. Serum sodium may be low if kidney wastes sodium or normal, reflecting dilution state of hypernatremia. And potassium may be elevated related to retention and cellular shifts in acidosis or tissue release, red blood cell hemolysis. In end-stage renal disease, we can see ECG changes if potassium is 6.5 or higher. Potassium may also be decreased in patients on potassium-sparing diuretics or when patients are receiving dialysis. Magnesium and phosphorus are usually elevated, and calcium to phosphorus could be decreased. All right, so assessment and diagnostic findings. So proteins, usually albumin is decreased serum levels may reflect protein loss via urine, fluid shifts, decreased intake, or decreased synthesis because of the lack of essential amino acids. Serum osmolarity is usually higher than 285. KUB X-rays demonstrates the size of the kidney, ureters, bladder, in presence of obstruction or stones. Retrograde pyelogram outlines the abnormalities of the renal pelvis and the ureters. Renal ardiogram assesses renal circulation and identifies extravascularities, masses. Voiding cystourethrogram shows bladder size, reflex into ureters, and retention. Renal ultrasound determines the kidney size and presence of masses, cysts, obstructions in the upper urinary tract. A renal biopsy may be done endoscopically to examine tissue cells for histological diagnoses. Renal endoscopy or a nephroscope is done to examine the renal pelvis and flush out calculi, hematuria, and remove selected tumors. An ECG may be abnormal, reflecting electrolyte and acid-base imbalances. And we can also do x-rays of the feet or skull or spine and hands to reveal any calcifications or demineralizations resulting from electrolyte shifts. Okay, here we go. So medical management. The goal of management is to maintain kidney function or homeostasis as long as possible. So pharmacological therapy includes calcium and phosphorus binders, which will treat hyperphosphatemia and hypocalcemia. We can use antihypertensive and cardiovascular agents such as digoxin or dobutamine to manage hypertension. We can use anti-seizure agents such as phenytoin or IV Ativan are used for seizures. Erythropoietin is used to treat anemia associated with end-stage renal disease. Nutritional therapy. So dietary interventions include carefully regulating the protein intake, fluid intake to balance fluid loss, sodium intake to balance sodium loss, and some restrictions on potassium. Also, dialysis is usually initiated if the patient cannot maintain a reasonable lifestyle without consecutive treatments. So, nursing assessment. We want to assess fluid intake and fluid status, assess nutritional dietary patterns, nutritional state, understanding of the cause of renal failure and its consequences in its treatment, assess the patient and family's response to restrictions that because of treatments and the illness, and assess for signs of hyperkalemia. These are just some different nursing diagnoses that we could use with these patients. So excessive fluid volume related to decreased urine output, dietary excess and retention of sodium and water, imbalanced nutrition, less than body's requirements related to anorexia, nausea, vomiting, dietary restrictions, and altered oral mucous membranes, activity intolerance related to fatigue, anemia, retention of waste products, and dialysis procedure, and risk for situational low self-esteem related to dependency, role change, changes in body image, and changes in sexual function. So planning and goals for these patients are to maintain an ideal body weight without excessive fluid, maintenance of adequate nutritional intake, participation in activity within tolerance, and improved self-esteem. Nursing priorities include maintaining homeostasis, preventing complications, providing information about the disease process and prognosis and treatment needs, and support adjustments to lifestyle changes. So our nursing interventions can include assessing the fluid status and identifying potential sources of imbalance, implement a dietary program to ensure proper nutritional intake within the limits of treatment regimen, promote a positive feeling by encouraging increased self-care and greater independence, and promote intake of high biologic value protein foods such as eggs, dairy products, and meats. And after scheduled of medications so that they are not given immediately before meals, and rest. Encourage alternating activity with rest. So our evaluation of these interventions will include maintained ideal body weight without excessive fluid, maintained adequate nutritional intake, participated in activity and with intolerance, and improved self-esteem. And again, these are just some examples because this is going to be based on how your individual patient responded to the interventions. And discharge and home care guidelines. So the patient should be taught how to check the vascular access device for patency and provide appropriate precautions such as avoiding venipuncture and blood pressure measurements on the arm with the access device. So this is for a patient who has dialysis. If they have a vascular access device, this is usually in their arm, and we want to teach them how to care for it. So problems to report. The patient and the family need to know what problems to report: nausea, vomiting, changes in usual urine output, ammonia odor on breath, muscle weakness, diarrhea, abdominal cramps, a clotted fistula or graft, and signs of infection. We also want to provide follow-up exams, and treatment is stressed to be patient and stress this to the patient and family because changing physical status and renal function and dialysis requirements are all things that need to be monitored. And home care referrals, so referral to any home care to help assess the patient in any of their changing statuses. And documentation guidelines. We want to make sure to document on existing conditions that contribute to and degree of fluid retention, I&O and fluid balance, results of lab tests, calorie intake, individual cultural or religious restrictions and personal preferences, level of activity, plan of care and teaching plan, responses to interventions and teaching, actions performed, attainment of progress towards goals and outcomes, modifications to the plan of care, and long-term needs. All right, and that is the end of chronic renal failure. If you guys like this video, make sure to subscribe and check out down below. I have a lot of free resources on my website, as well as an NCLEX study guide. I have a free pharmacology notebook. I have free cardiac study guides, a bunch of stuff on there. So go down and make sure to check that out as well. And I'll see you guys next time. Bye.